Hi everyone, we are moving on to our prostate and scrotal pathology. So again, we're going to be talking about benign and malignant findings that we can evaluate in ultrasound for both of these male reproductive organ systems. So we are going to be starting with our prostate, and just a few things before we get into any actual pathologies or conditions. There are some prostate variants that are not necessarily common in a lot of male patients, but they can occur. And if we are scanning either transabdominally or transrectally, we just want to be aware that we're not confusing these for something else. So we have these prostatic variants. We have agenesis of the seminal vesicle. Now, if we remember from our previous lecture, that seminal vesicle, that's going to be sitting right next to the bladder. It's not something that we are evaluating on ultrasound, especially transabdominally. But the thing that we need to be aware of is that this condition, if we don't have one of those seminal vesicles, it's going to result in a missing kidney on that same side. So basically in utero, when our genitourinary system is developing, our urinary system and our reproductive system both proliferate from the same primitive structures. So our kidneys are very closely related to anything abnormal that's happening in our reproductive system. So if we are missing that seminal vesicle, we are also going to be missing the kidney on that same side. We also can have what is called a prostatic utricle cyst. This is going to result in renal agenesis as well. This is not something that's going to be side specific. So it's not like you're always missing the left kidney or you're always missing the right kidney. You have this cyst within the prostate that is going to result in one or both of the kidneys being missing. As we know, if we're missing both kidneys, that is incompatible with life. So if we are scanning an otherwise healthy adult patient and they tell us that they have this particular prostate cyst and they're missing a kidney, that's going to kind of go hand in hand in terms of their patient history or clinical history. We also can have an ejaculatory duct cyst. As we know, that's one of the last kind of pathways of the male reproductive system. It's going to travel through that urethra to be expelled. So we can have a cyst along that ductal pathway. We also can have a Müllerian duct cyst. This is going to result in renal agenesis as well. And the Müllerian duct, kind of similar to the Wolffian duct that we talked about on the previous PowerPoint, is a very primitive embryologic structure that a lot of our other organs and systems are going to develop off of. You're going to hear that Wolffian duct and this Müllerian duct come back in a lot of our lectures. So this is not going to be the last time that we hear about either of those. And then we also can have agenesis of the vas deferens. Again, we can have that on either side where we just congenitally don't have a vas deferens transporting from the scrotal contents up into the pelvis of the patient. So we have some images on the right side. Now our image on the left and the image on the top right, these are both transabdominal images, and they are both showing these cystic-like structures. Now, we can't really evaluate the agenesis of the seminal vesicle or the agenesis of the vas deferens, but we can see these specific ductal cysts. So this first picture on the left side, that is going to be our prostatic utricle cyst. So you can see it kind of looks like just a cyst that's occupying the entire fossa where the prostate is going to sit anyway. So that's generally going to be the region where we're looking, kind of right in that midline region. And then we have our ejaculatory duct cyst. That's the picture that's going to be on the bottom right side, right central through that transrectal approach of that prostate. And then we have that Müllerian duct cyst on the top right, kind of situated between the prostate and the bladder. All right, moving into some of our prostate abnormalities. We talked about this a little bit in our previous PowerPoint. We have benign prostatic hyperplasia. This is also known as hypertrophy. They mean the same thing. It just means the abnormal proliferation proliferation of that glandular functional tissue of the prostate. So our prostate is made up of those functional cells, and over time, it just starts to keep producing and producing and producing these cells. That's what we say, that's what we mean when we're saying the word proliferation. We are continually producing this increased number of functional cells. So overall, this prostate is going to get bigger and bigger and bigger, hence the term hypertrophy or hyperplasia. The tissues keep growing. A normal prostate volume, when we are measuring our 3 measurements of the prostate, is going to be less than 20 milliliters for a volume. So anytime we see anything larger than 20 milliliters or 20 cc's, it's a very equivalent type of measurement, that is going to put us in the ballpark of BPH. Clinically, these patients are going to be aging male patients. Of course, as we get older, the prostate continues to proliferate, and they are going to have associated urinary symptoms. On ultrasound, we are going to see an enlarged prostate. We could see a hypoechoic central portion of the prostate. We also could see echogenic nodules or echogenic foci. We could see calcifications in the prostate as well. We could see some cystic changes in the prostate. And the reason why we see potential cystic changes and calcifications and echogenic foci, we see those in terms of conditions that have been happening for a while. So if we're seeing calcifications, if we're seeing a central cystic change, or we're seeing that tissue starting to turn into a fluid, this means that it's most likely a process that has been happening for a while. So think of like, I don't really know a good analogy or example for this, but something that just crystallizes over time, right? I guess diamonds kind of do that. They crystallize over time, and that's going to be the same thing with a lot of our organs and a lot of these conditions that we're going to talk about. So when we see calcifications, we see cystic changes, meaning the tissue is turning into a cystic region. That is all common for signs of degeneration. So that organ or that tissue is starting to degenerate. We are also with BPH going to see a compressed central zone and peripheral zone, and that's because if we remember from our previous PowerPoint, BPH is most likely going to occur in the transitional zone. So that smallest zone of the prostate is going to keep proliferating, growing, getting bigger, and it's going to compress on those other zones surrounding it. We are also going to see it starting to have some effect on the bladder. So that bladder wall is going to get thicker over time. We know that that bladder wall should be less than 3 millimeters in diameter. We could also see possible hydronephrosis and hydroureter, and that's because the prostate is compressing against those urinary jets, right at that junction where the ureters meet the bladder. So when we have this organ that's growing and growing and compressing on that region, it's not going to allow the urine to come in through that ureter, and it's going to cause a backup of that fluid into the ureter and then all the way back up into the kidney. Now, it's important to remember with BPH that a lot of prostate cancers can mimic this. So although this is a benign condition, it's not something that we just want to ignore. We want to prove that it's just BPH and that there's not a malignancy that's happening at the same time. So sometimes when we see this asymmetric enlargement of the prostate, meaning like only one spot of the prostate is enlarged, or we kind of see this focal bulging of one region, we want to make sure that that's not an actual discrete tumor or a possible malignancy. So we don't worry about BPH, but we want to make sure that we are proving that it's just BPH. So let's take a look at some pictures on our next slide here. So on the left side, we have a nice diagram kind of showing what happens to that prostate as it continues to proliferate. So in comparison to the normal prostate, you can see that that enlarged prostate has become a little bit more irregular, right? It's not nice and smooth in its texture. It's becoming more lumpy, more bumpy as those cells continue to grow and occupy more space. You can also see what's happening to that posterior, or rather that inferior bladder wall, right? It's kind of protruding up into that bladder. So we see the prostate on ultrasound look like it's starting to invade the bladder, but it's really kind of just compressing upon it. So if we look at our pictures on the right side, we see our irregular prostate kind of doing like this little shape. kind of bulging into that bladder there. We also see some calcification, so we know that this is a process that has been going on for a little while with this patient. And then we also kind of see on this view, in our sagittal view, kind of irregular, heterogeneous. And of course, we will want to be getting volume measurements to indicate that it is truly falling into the ballpark of BPH. Moving on to our prostatitis, this is what we call acute inflammation of the prostate, and this is commonly going to be caused by a particular bacterial strain. So this is a bacterial infection that causes the inflammation of that prostate tissue. Very easy to treat this with antibiotics, but if we don't treat this and we don't completely get rid of the bacterial strain, it can lead to an abscess formation, and it can lead to chronic inflammation, which we'll talk about in a second. So prostatitis is going to clinically present with urinary symptoms for the patient, of course, pain as well. On ultrasound, it can appear normal if it's a very early onset of this inflammation, but we're most likely going to see a diffusely hypoechoic peripheral zone. It's mainly going to affect that peripheral zone because, as we know, that occupies the majority of our prostate tissue. We are going to see that tissue become hypervascular when we're putting color evaluation on it. We could see the formation of a hypoechoic mass, and that just indicates the inflamed region of tissue. And then again, depending on the severity and how long this has been going on for, we could see an abscess starting to form. So picture on the top, this is a side-by-side transrectal image. We can kind of see a little bit of a hypoechoic region, but it's kind of hard to tell if that's truly a hypoechoic change in the tissue or if that's maybe just like the transitional zone. But when we put color on it, we can see that that tissue is lighting up more in this region here. So this is going to be our affected, inflamed prostate tissue. Picture on the bottom, I believe these are still transabdominal images, a little bit hard to tell since we're not getting a full view, but this is what it's going to look like when we have an abscess starting to form. So an abscess is an irregular collection of bacterial products. So any type of infection that we have can result in an abscess formation if it goes untreated for a certain period of time. So basically just continues to accumulate and get worse and worse and worse, and it forms its own little nasty gelatinous bubble of illness and bacteria, to put it politely. So here we have this change of tissue here. We have this irregular fluid collection. We have some of these calcifications appearing. Again, as we know, calcifications mean that this has been going on for a while, and abscesses typically only occurred from untreated or prolonged infections. We also see a little bit of free fluid surrounding that prostate. So that's going to indicate that the body is trying to fight something off as well. Next, we have chronic inflammation. So this is when we have recurrent or prolonged episodes of that prostate inflammation, of that prostatitis. Clinically, we are going to have a variety of symptoms for these patients depending on how long it's been going on for. Is it responding to the antibiotics? Is it not responding to the antibiotics? So this is really going to be a variable clinical presentation. On ultrasound, we could still see those focal hypoechoic masses. They're going to start to vary in echogenicity, again, depending on how old or how long this has been going on for. We should expect to see calcifications, and then we should see some thickening of the prostate surrounding capsule. So we're going to start to see some irregular walls and borders of that prostate as well. Typically, kind of like a little side note here, when we're talking about an acute process versus a chronic process, we're going to see this throughout all of the organ systems, but acute conditions result in enlargement, and as they turn into chronic conditions, that causes the organ to start to get smaller and smaller. So we initially see hypertrophy of organs that are undergoing an acute process, and then we see atrophy of those organs when they've had that for such a prolonged period of time. They are now considered chronic. So if we see a very small prostate, irregular prostate, chances are that's going to lead us to believe that it is a chronic episode of inflammation. Moving on to prostate carcinoma or prostate cancer, the majority of these are going to occur in the peripheral zone, and about 25% will be in the central zone of the gland. Not really seeing this too often in the transitional zone. Again, that transitional zone is only accounting for 5% of the tissue, so we wouldn't expect to see a lot of cancers forming there anyway. Clinically, we're going to see elevated levels of PSA. So remember that prostate-specific antigen that we talked about on the previous PowerPoint. Patient's going to have urinary symptoms, particularly hematuria. So they have blood in their urine. They are also going to have back pain. On ultrasound, we could see small hypoechoic nodules in that prostate. These can be really hard for us to visualize, especially if we are doing a transabdominal. Basically, if we're doing transabdominal of the prostate, we're really not going to be able to find these carcinomas or these cancers. Although they commonly are going to be hypoechoic, they can really be anything they want to be. They can be isoechoic, they could be hyperechoic, they could be mixed echogenicity, they could have irregular margins that kind of blend in with the surrounding tissue. So these really hide, and the main thing that's going to help us get a diagnosis is really going to be that blood work, getting back that PSA value. We could see these regions in the prostate become hypervascular, but again, we could very easily confuse that with the acute inflammation, right? Or the chronic inflammation. We could see an enlarged prostate. Again, it's going to make our job a lot harder when we're talking about other things that can look like this on ultrasound. We could see a distended bladder with thick walls and trabeculations, and we could also see bilateral hydronephrosis and hydroureter. So this is why it's really important for us to not just ignore BPH and to really make sure that that's all that it is, because a lot of these sonographic appearances of these carcinomas in the prostate look very similar to BPH and look very similar to prostatitis. So we don't want to just ignore those benign findings because we could be ignoring a carcinoma. And moving into our scrotal contents, so we have a lot of pathologies within the scrotum itself. So a few variants here, we have unilateral testicle, meaning our patient is only born with one. And then we also can have polyorchidism. So this is a really interesting type of variant that I have had the experience of scanning before. This is when the patient has more than 2 testicles. They typically have 2 on one side. And a lot of these patients don't even know that they have more than 2. So it's a very interesting conversation to have with your patient. Moving on to our cryptorchidism. This is also known as undescended testicles. We're going to talk about this quite a bit when we get into OB as well, but this is when our testicle has not fully descended into the scrotal sac, and that means that it is going to be positioned anywhere along the pathway between the retroperitoneum and the scrotal sac. When we are developing in utero, everything develops in our in terms of our genitourinary system. Everything develops in our pelvis and then moves to its respective regions. So our kidneys develop in our pelvis and then they ascend up into the flanks. Our ovaries and our testicles develop in our pelvis, and then the testicles should descend down into the scrotum. So if that doesn't happen, we want to make sure we're looking along that pathway where the testicle could have developed and stayed. So we're looking all the way up into the pelvis, and then we're even, if we don't see it in the pelvis, we're even going all the way up into the flanks to see if it's located near the kidneys. So these pictures on the right side, they are showing the testicles situated right next to those main vessels in the pelvis. So the common iliac artery and the common iliac vein. So that way we can prove that it is located in the pelvis and not located in the scrotal sac where it should be. Cryptorchidism is very important for us to diagnose very early on in childhood. It is associated with adult infertility in cancer because the testicles are just being continuously exposed to the high body temperature. When normally they should be in the scrotal sac, keeping the temperature lower. So that is going to result in lower sperm counts, and that prolonged heat is going to result in a higher risk of cancer into adulthood. So we really are evaluating for that really early on in a child's life. Next, we have a hydrocele. We kind of touched upon this briefly, but this is when we have the abnormal fluid collection between the 2 layers of the tunica vaginalis. So as we know, the tunica vaginalis has the inner visceral layer and the outer parietal layer. And we have a normal kind of trace amount of free fluid that typically sits there. But when we have this abnormal accumulation of serous fluid in between those layers, that's when we get a hydrocele. This can be congenital or idiopathic, meaning this is something that you have kind of been born with or have been dealing with your whole life, or the cause has been unknown. We can see a hydrocele occur with orchitis, spermatic cord torsion, and trauma. We're going to talk about that torsion and orchitis in a bit. But this is a very, very common thing that we're seeing on ultrasound, especially these severe cases. These patients will come in with a very, very enlarged scrotum. It's uncomfortable for them to walk. It's uncomfortable for them to sit. So they are in a lot of pain and discomfort when they are coming in for this. The testicle, or rather the scrotum itself, is almost like firm and hard to the touch because it's so swollen and it's being stretched so much by all of this fluid. So it's a rather uncomfortable situation for the patient. I actually have had a patient before whose scrotum was so large because it was so full of this fluid. It had such a large hydrocele that he could not lay down on the table. He had to sit off the edge of the table to let his scrotum hang because it was too large. It was the strangest situation I've been in a while, but you could tell how uncomfortable it was for him. So these things can get very, very large. We also have some additional fluid collections that we may be evaluating on ultrasound. Fluid collections anywhere in the body are a little bit hard to tell, like the true composition of it. We get a lot of these blood-filled collections, we get a lot of these pus-filled collections, and they kind of look a little bit similar to each other, so we need to get a good clinical history on the patient. We have what are called hematoceles, so this is when we have that accumulation of blood in the scrotal sac or in between the layers of the tunica vaginalis as well. This is going to be associated with any type of trauma or surgical intervention. So if the patient has had a vasectomy or an inguinal hernia repair, we could expect to see a hematocele accumulating in the scrotal sac. We also have what are called pyoceles. These are going to be accumulations of pus. This is going to be associated with epididymis or orchitis. We're going to talk about those in a second, but basically when we have any type of bacterial invasion going on, we're going to get this accumulation of pus as our body tries to fight it off. So they look kind of similar to each other. These are not going to be serous-filled fluid collections. These are made up of blood or pus, so they're not going to be perfectly anechoic. Blood does this very interesting thing on ultrasound where depending on where it's accumulating in the body and how old it is, it starts to change its echogenicity. So with certain findings, new blood is going to appear very hypoechoic. Old blood is going to appear very hyperechoic. And then in other parts of the body, if we have a new blood collection, it's going to appear hyperechoic. And if it's an old blood collection, it's going to appear hypoechoic. So blood is very tricky when we have these blood collections or accumulations throughout the body. So you're going to notice that throughout the semester as well. And for both of these, this is the testicle, this is the testicle, this is all of the blood accumulating. See how it's not perfectly anechoic? And same thing down here. This is all of the pus accumulating. You have some septations in there, echogenic debris in there. So both of them are not nice and pretty. Moving on to more of our inflammations. First, we have epididymitis. So this is going to be the inflammation of epididymis. This is going to be the most common cause of acute scrotal pain. So when a patient comes in with scrotal pain, the thing that we're mainly concerned about is a torsion. And if it's not going to be a torsion, it's most likely going to be some type of itis, whether it be epididymitis or orchitis. So clinically, the patient is going to have fever, pain, dysuria, trouble urinating, and urethral discharge. This is going to be caused by an infection, a bacterial infection. So we would expect to see other types of infections with that patient clinically as well. So that fever, that urethral discharge, those are all going to go hand in hand in terms of that diagnosis. We're not going to see that with a patient who has a torsion. So that's how we can kind of tell the two apart clinically. On ultrasound, the epididymis is going to appear enlarged, especially the head of the epi. We're going to see thickened scrotal skin. Remember, we want to see that skin measuring less than 3 millimeters in AP diameter. We are also going to see a hydrocele starting to form, as we previously said, and we are going to see increased vascularity when we are using our Doppler, particularly in comparison to the opposite epididymis. Now, you can have epididymitis in your right epi and not have it in your left epi, but usually if you have some type of infection going on in your reproductive system or in your scrotum, it's going to reach its nearby neighbors. So it's going to reach that testicle. It's going to reach the opposite side at some point. If you catch it really early on, maybe not so much, but if you've been sitting with this type of infection and inflammation for a little while, chances are you're going to see it in both epis and potentially in both testicles as well. So speaking of, we have orchitis. This is the inflammation of the testicle, very similar to epididymitis. The two are actually seen together in at least 20 to 30% of cases. So if we're seeing epididymitis, chances are we're probably seeing orchitis as well, and we call that epididymo-orchitis. We just combine the two terms. Chlamydia is going to be the most common cause, so that is going to be that main, I don't want to misspeak here, I'm not sure if chlamydia is a bacteria or a virus. I think it's a bacteria. I don't know. This is a good question. I'm probably going to look it up as soon as I'm done recording. I'm curious. I'm looking it up right now. Bear with me. Oh, it's the bacteria. Okay, good to know. So it is going to be the most common cause of this type of infection, therefore resulting in inflammation of the testicle itself. We also can see orchitis in cases of mumps, any type of other virus, or sometimes just an unknown cause. The testicular tissue can just become inflamed on its own. So pretty rare and strange for that to happen, but STIs, particularly chlamydia, are going to be the most common causes for both orchitis and epididymitis. Clinically, again, talking about pain, fever, discharge. On ultrasound, we are going to see a hypoechoic testicle that is going to be very hypervascular. So when we put that color on, it's lighting up like fireworks on the 4th of July. Moving into our torsions. So this is where our job becomes very, very important. This is a very time-sensitive situation. A torsion is when the testicle either twists on itself or it twists on its blood supply. Now, when we have a spermatic cord torsion, this is when that spermatic cord, which remember is that suspension of the scrotum, of the testicles in the scrotum and connects everything back up to the inguinal canal. When that spermatic cord twists on itself, it's going to cut off that arterial blood supply. Now that arterial blood supply, if those tissues aren't getting that blood flow, they're going to start to die off. And that is what we call ischemia, when we don't have blood supply, and necrosis is when we have tissue death because of ischemia. This is commonly caused by belt and clapper deformity. This is a congenital deformity that some male patients can have in terms of their anatomic structure of their spermatic cord. Acute conditions of spermatic cord torsion are going to result in severe scrotal pain and swelling, very rapid onset, nausea and vomiting because that pain is so severe. On ultrasound, we're going to see a variable appearance, but we're typically going to see an enlarged testicle and epididymal head with decreased echogenicity. So it's going to start to appear hypoechoic. We're also not going to see any color flow getting into the testicle and the epididymis, right? Because we've cut off the blood supply in the spermatic cord. So now the scrotal contents are not getting anything. We also can see this twisting and looping of the arteries up in that region of the inguinal canal. So we can actually follow that spermatic cord up and find where those arteries are twisting on themselves. If we have chronic conditions of spermatic cord torsion, we can have a fever, we can have urinary symptoms. On ultrasound, these testicles are probably already going to be dead, so they are going to appear very small. They are going to appear heterogeneous with infarcted regions. Infarcts means little pieces of tissue that have already died off. The scrotal wall is going to appear thickened. We could see a possible hydrocele. Again, we're not going to see any color, any vascularity at all in the testicle and the epididymis and even surrounding the testicle itself. When we say that this is a time-sensitive situation, if we can diagnose this and get the patient into the ER within 6 hours, it's a 90% chance of saving that testicle. If we reach the 24-hour mark, we only have a 10% chance of saving that testicle. So these structures really cannot go that long without getting any blood supply to them. So here is what this is going to look like on ultrasound. Particularly the image on the right side is kind of what we're looking for. So the picture on the right side, we're seeing a side-by-side of the right testicle and the left testicle. Right testicle, we're getting color flow, normal echogenicity, probably measuring normal in size. And then we look at that left testicle, it is heterogeneous, it looks enlarged, it looks kind of swollen, we're not getting any color flow on it. So we are going to assume that that is an acute torsion on that left side. Now, on the picture to the left of our screen, we can actually see the twisting of that spermatic cord next to the testicle. So next to that right testicle, we see all of this tortuosity here, right? Like this kind of just looks like a big whirlpool of vessels. That is going to be the vessel twisting on itself, cutting off blood supply to that right testicle. And as you can see, the left testicle is still getting normal color flow. Next, we have intermittent torsion. So similar to a spermatic cord torsion that's associated with that bell and clapper deformity, we can get this twisting that comes and goes. So the testicle itself with intermittent torsion actually twists on its own tissue. So it's not twisting on its artery in the spermatic cord, it's twisting on itself and then it's untwisting. So the testicle's mobile in there, right? It's not completely like structured. It has a little bit of free range. So it's moving depending on the patient's positioning or activity. It can kind of twist on itself and then untwist. Twist on itself, untwist. So they get these intermittent episodes of this pain and these symptoms similar to torsion, but then sometimes when they come in, we're still getting color flow in the testicle. We're not seeing the torsion on ultrasound, but it doesn't mean that it's not happening. We're just not catching it in that moment. So acute types of intermittent torsion, again, going to be very similar in clinical symptoms as spermatic cord torsion. Even on ultrasound, if we're catching it during that episode of torsion, it's going to appear very similar, that enlarged, decreased vascularity. If we are catching it immediately after it resolves, it's not going to show us anything pertinent. So we almost have to like catch it with the patient, which can be rather frustrating for them because they think that they're going crazy and they think that there's something wrong and we're just not seeing it on imaging. With that, a hydrocele is common, but hydroceles are common for a bunch of different reasons. So we wouldn't really know to diagnose intermittent torsion if it's in the resolution phase of it. Our next form of torsion is going to be partial torsion. So this is when only a portion of the testicle has a compromised blood supply. It's important for us to make sure that we are comparing the testicle that is partially torsed to the opposite testicle. We don't want to confuse a partial torsion with polyorchitism. So this picture here, this could very easily be confused for two right or left testicles. In fact, it's just one testicle that has twisted on itself, resulting in a partial torsion. So we really need to make sure that we are comparing, we're getting great clinical history, and we're using our other clues to help us get a definite and accurate diagnosis. On ultrasound, this is going to be often missed. So we kind of just, it's unfortunate, but we kind of will have like a specific area of the testicle that may not be lighting up with a lot of color, but the rest of the testicle is lighting up with color, and we kind of just think that maybe it's just my machine, maybe it's just my color settings, but I'm getting flow throughout the rest of the testicular tissue. We can't do that. That is ignoring a potential partial torsion. So we need to make sure we're getting a good color flow evaluation throughout all of the testicle on both sides. Now, if we look at this example on the right side, this is one testicle. It's twisting here. And then this is a torsed region. And this is a torsed region. Right? So we're still getting color flow throughout the testicle. It's still getting some blood supply, right? But those particular regions are not. And it's a little bit hard for us to diagnose that on ultrasound, and that's why it is often missed. Next, we have a spermatocele. So this is a cystic dilation of those efferent ductules. As we said, that connects the testicular tissue to the epididymis. It's a lesion of the epididymis that actually contains spermatozoa. It's commonly going to be seen after a vasectomy because when we go in there interventionally and we create a little outpouching or a little surgical scar, that allows for some of the little sperm to escape and kind of accumulate in that region. Clinically, the patients are going to have painless jaundice, which is interesting because jaundice is a liver condition. So their skin is going to start to appear yellow. It's going to be painless for them. They could have a palpable mass. They could also have onset of diabetes, weight loss, and abdominal and back pain. So this is a type of condition that's pretty random. It has a lot of randomly associated clinical symptoms. Onset of diabetes, I can't particularly tell you why that would be. Just a lot of interesting clinical associations with something like this. So on ultrasound, we are going to see these located at the epididymal head, of course, because it is something abnormal with those efferent ductules. They could potentially have internal echoes and septations, as we are seeing in both of these examples here. And they typically are going to have nice, smooth walls. So these are benign conditions, but as we previously just discussed, they could have some more severe associated clinical symptoms. Next, we have varicoceles. These are very common. We see these quite a bit on ultrasound, and we just need to be aware of how we should be evaluating them. These are enlargements of the spermatic cord veins. So as the veins are traveling through the spermatic cord, they become enlarged. This is going to be the most common cause of infertility, and the reason why that is because vessels, whether it be veins or arteries, are going to inherently have heat associated with them. Now, when we have these enlarged veins, we're going to have more heat in that area, right? Because the veins are bigger than they should be. If we have more heat in the area of our reproductive organs, we know as a man, we need to keep temperatures low for healthy sperm. So if we have these enlarged veins that are bringing heat to this area, it's going to result in infertility. So it's very easy to fix varicoceles. It's very easy to treat them. But that's something that they are initially evaluating you for if you are going for infertility treatments as a male patient. The majority of varicoceles are going to occur on the left side due to that venous drainage that we have going right into that left renal vein. Remember when we said on our previous PowerPoint that that left side is always going to be slightly different than that direct drainage on the right side. We could see large right-sided varicoceles associated with kidney tumors. So anytime you see a varicocele, particularly on the right side, but anytime you see a varicocele, whether it be left or right-sided, you should always check the associated kidney for any type of abnormality. Our kidneys, as we've previously said, are so closely related in terms of development to our genitourinary system that if we see something abnormal with something in the male reproductive system or even the female reproductive system, we need to go and check the kidneys and make sure they are okay as well. Clinically, we are going to see patients with tender palpable masses. They can be asymptomatic. On ultrasound, we are going to see dilated, enlarged, patent veins. When we say patent, that means that they are working properly. There's nothing abnormal about the vein itself, other than the fact that it is dilated. If it was thrombosed or clotted, it would not be a patent vein. Patent veins mean blood flow is still traveling through them properly. We also want to make sure that we are using our Valsalva technique. So we are having our patients squeeze their belly to make sure that we can see those varicoceles all fill with blood flow. Next, we have cysts. We can have intratesticular cysts. These are mainly just going to be made up of serous fluid, nothing to be concerned about. We also can have what are called epidermoid cysts, and I don't really like associating it with the term cyst because a cyst in the ultrasound world means a benign serous fluid filled structure. An epidermoid cyst is not made of serous fluid. It's made of keratin and epithelial tissue. Now, the term dermoid is something that we are going to come back to, and we're going to see that especially when we get into our GYN class, but we'll get to it in a second as well. Dermoids are petrifying because they are made up of very primitive structural tissues. Picture on the left side here, this is going to be an epidermoid cyst. You can see it's kind of got like this weird circular pattern, kind of like a bullseye target in there. It almost looks like perfect in that testicle. And then that intratesticular cyst on the right side looks like our normal cyst that we would see anywhere else in the body. Next, we can have an abscess. We've talked about this already, but this is mainly going to be caused by untreated epididymo-orchitis. We are mainly going to see these abscesses forming in the extra-testicular space, so meaning the space outside of the testicle rather than actually occupying space inside the testicle. And that's just because of it's easier to form this nasty bacterial fluid collection in a region where it doesn't have to fight anything. Like if it's going to form in the testicular tissue, it has to fight against all of that other functional tissue. It can just grow outside the testicle much easier than it can inside the testicle. And that's why we see them extra-testicularly more common. Clinically, fever, pain, swelling, all standard symptoms of an abscess or infection. On ultrasound, we're going to see an anechoic, but mainly a complex mass, meaning it has mixed solid and fluid components. We're going to see increased peripheral vascularity, and that's the body's attempt of trying to fight that off by getting blood supply to it. And then we're also going to see no vascularity within the mass, and that is because it's mainly going to be filled with nasty fluid and pus. Next, we have a scrotal hernia. This is the bane of every ultrasound tech's existence. Extremely hard for us to diagnose, especially when they are small. But this is when we have an abnormal defect in the abdominal or the pelvic wall. We have some kind of weakness in that particular area, and it allows for the protrusion of the patient's bowel to go right through that canal into the scrotum itself. So we know our spermatic cord is that main pathway between the scrotum all the way up into the inguinal canal into the patient's pelvis. So if we have a weakness that's occurring in that region of the inguinal canal, it's very easy for the bowel to protrude right through it. Clinically, we are going to see a patient with groin pain, scrotal pain, and they're also going to have difficulty with defecation. And that's because if we think about it, their bowel is literally getting sucked through this little like hole in the wall, and it's not allowing all of the feces to travel through properly. That's really with any type of hernia, particularly in the abdomen. If there's bowel protruding through an area that it shouldn't be protruding through, it's going to make defecation much harder for that patient. On ultrasound, we could see peristalsing and slow-moving bowel within that scrotal sac. We're going to see free fluid, and we also want to make sure that we are doing a Valsalva technique. So again, we're making that patient increase the pressure in their abdomen to see if we can get anything to protrude through that weakness. Here we have 3 great examples of what hernias, and particularly scrotal hernias, are going to look like. First image on the left side, we see a lot of hernias in male patients, particularly in their inguinal canal, because they're doing a lot of heavy lifting. And they're doing a lot of squatting, they're doing, a lot of movements that are putting increased pressure on those lower pelvic abdominal wall muscles. So we're getting that weakness in between those muscle layers. So here we have muscle layer, and here we have our defect. So here's our weakness. This is all skin, subcutaneous, fat. right? This is going to be where our muscle comes in, protective layers underneath, and then we're going to have bowel hanging out down there normally, right? So now we have this defect right there. It's allowing for that bowel to come through, and that is going to be this whole hernia right here coming through. Now, if we look at that picture in the middle, same thing, but now we're looking closer to our scrotal sac. So we're actually seeing left testicle here. We even have a little bit of free fluid showing here and here. But this is the whole hernia coming down into that scrotal sac. So that's all bowel coming down into that scrotal sac. Same thing with this example here. This is all bowel coming in. So when we have our patient Valsalva, we have the weakness, right? And when we may not see the hernia at first, but if we're scanning in the area of pain or where the palpable mass is, and we have them Valsalva, we're going to increase pressure in this region, right? And then we're going to see the bowel go whoop right out. And then as they relax, it's going to go whoop right back in. So hernias are really, really hard for us to diagnose on ultrasound. But if you ever see bowel in the scrotum, you know that you shouldn't. Moving on, we can get hematomas in the scrotum as well, particularly in the testicle. So it's going to be a contained blood collection in the testicular tissue itself. Not really seeing these in the extra-testicular region, mainly because these are going to be caused by trauma or surgical intervention in the scrotum. So we're going to get that blood accumulation in the testicular tissue because that's the tissue that has been damaged for whatever reason. They kind of look like masses, so we need to be aware of our patient clinical history and making sure that they don't have a history of metastatic disease or lymphoma or anything like that, because they can mimic similar conditions. Before we get into some tumors, we need to talk about tumor terminology. So in the male reproductive system, and even when we get into GYN with the female reproductive system, there are so many tumors that we don't actually teach you about all of them because it takes too long. There's a lot of subtle differences between a lot of these tumors, and they all kind of fall into these particular categories that really are very primitive, meaning like from early gestational age, like early fertilization of an egg and a sperm basically can determine if some of these tumors are going to form. So there's some terms that we need to talk about, and we see a lot of these tumors in the male reproductive system and also in the female reproductive system. So we're going to come back to a lot of these over the summer. First, we have what are called pure tumors, and these are comprised of germ cell and stromal cell tumors. Germ cell tumors are any cell that is considered a reproductive cell. There are 3 layers of the germ cell. We have the ectoderm, the mesoderm, and the endoderm. Now, when you are just a very early little embryo, not even an embryo at that point, when you are a sperm and an egg that have met, one of the very first steps that human biology takes are these very primitive 3 germ cell layers. So basically, you've joined as an ovum and a sperm. You've become a blastocyst under rapid cleavage and cellular division, and now you've kind of formed this little blob of cells, and these cells are trying to determine like what their function is going to be. What are they going to be responsible for? So these 3 very primitive germ cells are going to be the ectoderm, mesoderm, and endoderm. The ectoderm is going to form the exoskeleton of the baby. So that's going to be responsible for forming a lot of our structural components. The mesoderm is going to be responsible for forming a lot of our organs, and the endoderm is going to be more of a protective layer. So it's going to form the inner lining of our organs. So these are all 3 very primitive types of germ cells, starting very early on. Now, when we have these tumors that are made up of these germ cells, that's when we get into this pathology. So the common germ cell tumors that we're going to talk about, particularly for the testicles or for the male reproductive system, we're going to be talking about a seminoma, an embryonal, or also known as a yolk sac, depending on the patient's age. We're going to talk about that in a second. Choriocarcinomas, and either teratomas, also known as dermoids. We're going to talk about those as well. Now, another form of a pure tumor is going to be a stromal cell tumor. So any tumor that is made up of structural cells. So a little bit different than the ectoderm. These are not ectoderm cells. These are going to be stromal cells. This is all on such like a very like primitive biology level. We don't need to get too far into it. I just want you guys to have a good understanding of how these cells are all forming and how they are categorized when we see these tumors. Now, these are all pure tumors. So this means that they are made up of particular types of cells. These 4 tumors here, these are all made up of those reproductive germ cell tumors. Stromal cells, these are all made up of that particular type of structural cell. So these are pure tumors. Now, we can have a combination of these germ cell tumors or of these stromal cell tumors, and those are going to be what we call mixed germ cell tumors. This is when you have at least 2 germ cell tumors combined, making up its own type of mixed tumor. So don't lose me here. We're going to talk about these. We also have non-germ cell tumors, meaning we have reproductive tumors that originate from cells that are not germ cells. So we have Sertoli cell tumors, we have Leydig cell tumors, and then we can also have mixed non-germ cell tumors, which is known as a Sertoli-Leydig tumor, a combination of non-germ cell tumors. Bear with me. We're not going to get too crazy. We also have theca cell tumors. These are also known as thecamas. These are made up of endocrine cells, so a little bit different. Again, we're not talking about reproductive here or structural. We're talking about endocrine cells resulting in theca cell tumors or thecamas. And then we also have adenomas and adenomatoids. Adenomas we are going to see anywhere in the body. This is a tumor that is made up of functional tissue cells specific to that organ. So you can have an adenoma anywhere in your body if it's associated with an organ. Now, we can also have an adenomatoid tumor anywhere in the body because it is made up of the cells that line that particular organ. So adenomas are going to be made up of functional cells of a given organ, and adenomatoid tumors are going to be made up of the cells that line that organ. So more of those epithelial cells of that particular organ. That was a lot of information, I feel like. All right, moving into some of our tumors, we have extra-testicular. So this means these tumors are going to occur outside of the testicular tissue. Now, our first one is going to be our adenomatoid tumor. As we said, it is comprised of those cells that line the organ. So this is occurring from the cells that line the testicle tissue itself. So it is occurring outside of the testicle. Most common form of an extra-testicular tumor. These are benign, they grow super slow, and they are going to appear as an asymptomatic mass. That is what this picture on the right side is. This is an adenomatoid tumor, and we have our testicle right here. Now we also have non-germ cell tumors that can occur extra-testicularly. So we can see a Leydig cell tumor outside of the testicle. We can also see a Sertoli cell tumor outside of the testicle, and we can see a cyst adenoma. These are not going to be more common for us to see outside of the testicle, but we can see these outside of the testicle. Mainly, we're going to see an adenomatoid tumor. All right, moving into our germ cell tumors, particularly of the testicle. Our first one, as we said, a seminoma. This is going to be the most common type of germ cell tumor. This is cancerous, this is malignant. This accounts for 50% of all germ cell tumors, and it is going to occur in men who are between the ages of 40 and 50. It's not super aggressive, so it has a pretty good prognosis in terms of a malignancy. Clinically, a patient is going to have a palpable lump, really no other symptoms associated associated than that. On ultrasound, we're going to see a hypoechoic lesion with smooth, well-defined borders. Next, we have our embryonal carcinoma. Again, another germ cell tumor. So this is going to be malignant, very rare, only accounting for up to 3% of all germ cell tumors. This is going to occur in young men, so 20 to 30-year-old males. This is highly invasive, so it doesn't really have the best prognosis. Clinically, we're only going to be seeing men who have a palpable lump. On ultrasound, we're going to see small hypoechoic area. We could see areas of increased echogenicity on the other hand. So again, it's kind of variable in appearance. You're going to see calcifications. And again, we know calcifications are representing something that's been there for a while, and that's why these are very invasive. So they're going to move quickly. We're going to see irregular borders of that mass, and we're going to see possible cystic areas. So this is a really good image showing us those cystic areas within the mass itself, also showing us irregular border right here. Right? And it's kind of discrete in its echogenicity. So we're not really seeing like a super hypoechoic area or even an area that's very hyperechoic either. So kind of discrete. Again, we're looking at our clinical history here. We're looking at the patient's age. We're looking at their symptoms. Now, if this is something that we see in a child who is younger than 2 years old, this is the infantile version, and that is what we call a yolk sac tumor. So again, we're aware of our patient's age and their clinical history with this. We're not going to call it a yolk sac tumor if the patient is 15, right? We're going to call it an embryonal carcinoma. Moving on, we have a teratoma. So this is also known as a dermoid. These are petrifying. They're a type of germ cell tumor. They're malignant. They're aggressive but rare. And they contain cells from all three types of those germ layers. Now, when we say that they contain cells, that means that it's going to have bone cells, it's going to have skin cells, it's going to have organ cells. So these things can get very ugly when they're surgically removed. Women tend to get these pretty often in their ovaries, and they're actually more of a benign condition. They're kind of like a precancerous condition if we see it in an ovary, whereas it's a little bit more malignant when it's in a testicle. When these things are removed, they literally look like they have bones, and they're like hairy and furry when they remove them. It's so gross. But teratoma, dermoid, they're kind of interchangeable terms for this type of tumor. Clinically, the men are going to present with a painless lump. These lumps are going to be firm because they are made up of bone cells, and teeth cells, and eye cells. Any cell really is going to be in that thing. So they're just gross. Maybe I'll try to find a picture and put it in our module, and I'll put a disclaimer if you don't want to see anything like that. We are also going to see calcifications. We'll see a complex mass, and they often have cystic changes. Now, again, these are made up of all different types of cells, so we're not going to see this nice, beautiful, homogeneous mass, right? We're going to see it become heterogeneous because it's made up of so many different components. And here is our teratoma with our calcified bone and teeth nastiness. Okay, and lastly, for our germ cells, we have our choriocarcinoma. This is going to be the rarest type of a germ cell tumor. It's actually the rarest of all testicular cancers. It's super malignant and super aggressive, again, occurring in young males, 25 to 30. They're going to have a painless lump. We're going to see irregular borders. We could see a complex lesion. Going to see these also associated with metastatic spread. So these are going to spread out pretty easily because of how aggressive they are. Now, these are going to have high levels of what we call beta HCG, and this is beta human chorionic gonadotropin. And human chorionic gonadotropin is one of the first markers of gestational life. And when we say beta, that means we're testing it through the blood. So when you're very early in your pregnancy and they take you for blood work, they are testing you for your levels of beta HCG to see how much HCG is traveling through your body to represent a normal, healthy early pregnancy. Now, again, if we're testing this on a guy, we know that we really should not see levels of beta HCG. So that's going to lead us to believe that there is some type of issue going on with the reproductive cells or the germ cells in that patient. So that blood work is going to correlate to this type of very rare and aggressive cancer in a male patient. We also see choriocarcinomas in female patients as well, and they kind of do the same thing in the uterus. We get these high levels of beta HCG in a woman who is not really pregnant. So it's kind of a little bit of a tricky situation to navigate that. And same thing with this picture here. Here's our right testicle, and we are using our curved transducer, and look how large that left testicle is to that in comparison to that right testicle. So it's super, super aggressive and can get very large and complex and irregular, metastatic spread, all that nastiness. And then just kind of briefly, we have our mixed germ cell tumor. This is when we have a combination of any of the germ cell tumors. This is obviously going to be considered malignant since all of the other germ cell tumors are considered mainly malignant. It's going to be the second most common tumor after a seminoma. So we do see like a choriocarcinoma in conjunction with an embryonal carcinoma, right? We can see those combinations. So that's why it's going to be more common than some of them just on their own. Next, we're getting into our non-germ cell tumors. We have our stromal cell tumor. This is a Leydig cell tumor. These are usually going to be benign, but 10% of them can be malignant. So again, we're not going to ignore them. This is going to develop from the Leydig cells. Again, very primitive cell of the reproductive system. They are responsible for releasing testosterone. It's going to occur in males 20 to 50 years old. Clinically, they are going to develop gynecomastia, which is the presence of enlarged mammary tissue in a male patient. They are going to have impotence. They are also going to have loss of libido. On ultrasound, we're going to see a homogeneous mass. We could also see focal areas of hemorrhage and necrosis in 25% of cases. We could see a small solid hypoechoic mass with peripheral flow. And next we have our Sertoli tumor, another type of stromal cell tumor. We can see these Sertoli-Leydig cell tumors combined. So we oftentimes see Sertoli tumors in conjunction with Leydig cell tumors. It's not our responsibility to differentiate between the two, but in terms of our boards and our overall education, we should know what makes them different, and that we can also see them in conjunction with each other. So similar to Leydig, it's typically going to be benign. 10% of cases are going to be malignant. They develop from Sertoli cells, which help the sperm to mature. They're rare, accounting for less than 1% of all testicular tumors. This can occur in men of any age. Clinically, they're going to have a painless lump. They're going to have feminine characterization. They're going to have gynecomastia as well. Feminization, that means they're not going to have as much hair production, muscle mass. Their voice won't be quite as deep. So just those overall physical characteristics. On ultrasound, these tumors are going to be small and hypoechoic. Now, if we look at this one compared to this one, I mean, you really can't tell the difference, right? So that's not going to be our job. But when we find something like this and we present it to the radiologist, we need to say, hey, I found this really small hypoechoic mass. My patient is complaining about enlarged breast tissue. I know that it could be some type of stromal cell tumor, maybe Sertoli, maybe Leydig, maybe Sertoli-Leydig combined. So we want to make sure that we have our education to support us when we're presenting these to a physician. Next, we have a granulosa tumor. This is another type of stromal cell tumor. Depending on how old you are, it depends on the seriousness of this. If you are an adult, this is typically going to be malignant with the potential of metastatic spread. If you are a child or an early teen, this is mainly going to be benign. So if you have this as a teenager and you don't know it and you age, and now you're 30, 40, 50 years old, well, chances are this typically benign mass has probably turned malignant at this point, and has a chance to spread metastatically. So when it developed from the embryonic sex cord, so again, a very primitive developmental structure, clinically painless lump, gynecomastia. On ultrasound, we cannot differentiate this from other types of testicular tumors. Again, I mean, like, look at that. It kind of looks like the Sertoli, kind of looks like the Leydig. And those are all stromal cell tumors. So it's really hard for us to differentiate that. This would get further imaging and further testing. Really, all of these are going to get further imaging and testing. Next, we have theca cell tumors. As we said, these are also known as thecamas. These are more common in ovaries when we're looking at a female patient. They're very rare in testicles, but they develop from theca cells, which both genders have, and our theca cells are responsible for producing androgen. Remember, theca cell tumors are going to be endocrine tumors, so they are responsible for producing those hormones, and androgen is going to be one of the main ones that they are responsible for producing. We'll learn more about thecamas when we look at ovaries as well. And metastatic disease, spread, lymphoma, and leukemia. Mets to the testicles or to the scrotum is very, very rare. If we do happen to see that, we're going to have a palpable lump. They're going to appear solid, hypoechoic lesions. We're mainly seeing Mets from the prostate or kidneys to the scrotum. So if you have lung cancer, we're really not going to see Mets down to the scrotal contents. But we know our prostate is so closely related to our scrotum, and we know our kidneys are so closely related to our male reproductive system that those two origination sites kind of make sense for that spread. Also, lymphoma and leukemia. So lymphoma, we are going to see, if we see lymphoma spreading to the testicles, we are going to see enlarged testicular tissue, diffuse or focal areas of decreased echogenicity. Overall, we're going to see weight loss, anorexia, weakness, typically in men over 60 years old, and it only accounts for about 1% of all testicular tumors. So again, not really seeing a lot of lymphoma traveling to the testicles. Same thing with leukemia, mainly only going to see this in children, and about only 8% of leukemia children or patients have testicular involvement. So not super, super common, but again, anytime we see any type of tumor or abnormality in the scrotum, in the testicles, we in the prostate as well, we need to make sure that we are getting further evaluations. We are getting that patient another exam ordered. We're getting them blood work ordered. We're surgically removing things that shouldn't be there. So tons of information on this PowerPoint. Hopefully you're making great progress on your pathology charts. If you have any questions about any of this stuff, please feel free to reach out to me. Again, I'm going to try to post a picture or a video of a dermoid or a teratoma on our page. So if you're interested, feel free to look at that. If not, I don't blame you.